cardiac ablation is ablation of the heart. So ablation refers to a controlled destruction of tissue. It's used in a variety of medical specialties to control symptoms typically. Neurosurgeons will use ablation to ablate spinal nerves that are leading to refractory pain. Women with bleeding uterine fibroids, ablation can be done to destroy that tissue, to cause it to shrink down and prevent those blood vessels from bleeding. And cardiac ablation simply refers to ablation performed on the heart, controlled destruction of tissue directed to the heart for the purposes of treating a mechanical or much more likely an electrical abnormality. In fact, almost universally, it's an electrical abnormality. We are seeing some application from a mechanical perspective as well. So that's what cardiac ablation is used for. It can be used to treat a variety of arrhythmias, including atrial fibrillation. There are different types of cardiac ablation, really referring to the energy source. The first ablation that was done was a direct current energy that was delivered through a single shock that was analogous to cardioversion, or analogous to delivering a shock to somebody, but it was all directed through a catheter. And so that all of that energy was delivered through the catheter in a single explosive delivery of energy, and it was hard to control, and it would destroy the tissue that was at the end of the catheter. It would achieve results, but it could be destructive to the heart muscle as well, and because of that, very dangerous. That was sort of first discovered in the 1980s by Mel Scheinman and others. Subsequently, it was discovered, or what was developed was a way to use alternating current. And radiofrequency is an energy source that has an alternating current that we use today. So radiofrequency ablation allows a controlled delivery of energy, whether it's power and watts and temperature that can all be evaluated at the tip of the catheter, over a controlled delivery of that energy, meaning over many seconds to minutes, to achieve a much more controlled result. And it's typically delivered through the end of a narrow catheter, and so the end result is a point-by-point ablation. And when those point-by-point ablations, which can be usually around 4 to 6 or 7 or 8 millimeters, are delivered adjacent to each other, then you can create a solid line of ablation, and that solid line could circumscribe a vein, or it could be delivered in a linear manner between two objects that don't conduct electricity to block a circuit, or in a focal manner. If the arrhythmia is arising from one small area, just 1 or 2 lesions can take care of it. We also have, so that's sort of this concept of putting heat into the muscle, heating the muscle, cooking it effectively to destroy the electrical properties. And it also results in destroying the tissue architecture. Or we have the reverse of that, which is pulling heat out or freezing the tissue, which also has similar effects, destroys the tissue architecture, alters the electrical properties, sometimes permanently. Generally speaking, the cryotherapy or the freezing therapy has not been found to be quite as effective or permanent as the radiofrequency heating approach. And sometimes that's good. If you're ablating in areas that are very sensitive, meaning that the area that you're trying to destroy is very close to a sensitive and important structure, that you don't want to create a lot of collateral damage, then some people will fall back on cryotherapy, so that because they know that if there is potential damage to the surrounding structures, then they can stop and allow it to thaw, and then you can often regain function of the tissue that was damaged through collateral damage, or that was injured through collateral damage. With the radiofrequency, once the ablation has been done effectively, you won't recover. You generally won't recover that. However, none of that can overcome the miracle of the human body to heal itself. So even with effective ablation identified at the time of the procedure, there can be sort of healing or reconnection of tissue at the area of ablation. So then there's laser energy. Laser energy can be delivered in a manner, typically through a balloon-shaped catheter right now is what we're seeing its application for AFib ablation. And that laser energy, again, can create a destruction of the tissue architecture and destruction of the electrical properties of that heart muscle to, again, render it electrically inert. But again, it does require some mechanical destruction, or it does result in some mechanical destruction as well. And then we now have even newer energy sources. The most recent development is something called pulse field ablation, in which we can use electricity to render the electrical properties ineffective or inert of that part of the heart muscle, and yet not have to destroy the tissue architecture. So it's truly an electromagnetic phenomenon rather than a destructive phenomenon, kind of like an EMP or an electromagnetic pulse that renders that area electrically inert without having to destroy the tissue architecture, with the benefit to patients being a potentially superior safety profile for that procedure. Yeah, the purpose of ablation for atrial fibrillation is to render certain areas electrically inert that do not allow the errant electrical impulses to trigger AFib, or do not allow the left atrial tissue or the substrate to create enough slowing of electrical conduction and chaos to create this erratic atrial activation sequence that we call atrial fibrillation. The purpose is not to simply perform ablation and destroy or change the electrical properties of the entire atrium, because then there will be no electrical impulses that travel through there. So it's actually much more focused and targeted in what we're trying to achieve. So ablation is typically used to treat electrical rhythm disturbances. As the most common arrhythmia, or the most common supraventricular tachycardia, or rapid heartbeat that arises from the upper chambers of the heart, aside from AFib, is called AV node reentry tachycardia. It's very common. We think it may be inherited, or just so common that 1 in 4 people will be born with the ability to have that through some period of their life. And we understand that circuit very well. We know exactly where that ablation needs to be performed. It's usually with just 1 or 2 lesions, and that arrhythmia is cured. It's gone for good. Other similar arrhythmias called supraventricular tachycardias can be as effectively ablated with a very, very, very high cure rate. There's a rhythm related to atrial fibrillation called atrial flutter. Atrial flutter has a few varieties. One of them is called typical atrial flutter. We know where it lives. It's on the right side of the heart. We know what the circuit looks like, and we know the most opportune area to ablate that is safest for the patient, and it has a very high success rate. Again, 95 to 98% success rate of cure. That rhythm is ablatable. Then there's rhythm disturbances that arise not from the upper chambers, but from the lower chambers of the heart, and those are called ventricular tachycardias. Some are occurring in a normal heart, some are occurring in people who have structural heart disease, like a prior heart attack. So in general, ablation is used to change the electrical properties of the heart muscle related to where the arrhythmia arises, not to destroy the heart tissue itself in other areas, because you want to maintain the electrical and mechanical properties. There's also a novel application of ablation specifically for people who have a condition called hypertrophic cardiomyopathy, where in some of those people, the muscle itself gets so thick that it interferes with the ability for the blood to actually flow out of the heart muscle itself. That's called the outflow tract. And we can see an outflow tract obstruction because as the heart contracts, the thickness of the wall just closes off that tract completely. And so ablation done in that area can destroy that tissue and cause that thickened muscle to regress and allow that outflow tract obstruction to be relieved to improve circulation and cardiac output, specifically in patients with hypertrophic cardiomyopathy. In people who are felt to be good candidates, and when the likelihood of achieving the goal that is appropriate for that arrhythmia or achieving the goal of that patient is high. So with most of these arrhythmias, we're talking about cure. When the likelihood is high and the risk to the patient or the risk of the procedure is low, ablation is recommended. The patient may say, that's not my goal. My goal is to avoid invasive procedures. Then we fall back on medications. But in some situations where the risk is high and the likelihood of success is low, we fall back on medications rather than using ablation as our first line. And then ablation becomes a second line only when we've got our back against the wall. When that person who's already potentially higher risk and who's got a low likelihood of success, but now finds themselves in the throes of another medical condition in which treating AFib is no longer tenable, such as the example I gave before, somebody who's having a bleeding diathesis who can no longer be protected from a stroke using a blood thinner. We then need to consider a high-risk surgical or catheter ablative procedure to get them through that procedure to avoid long-term risk of being on a blood thinner in the throes of a bleeding, in the situation of bleeding. Ablation itself is not something that is approved or not approved by the FDA. FDA typically clears or approves devices. But certainly the approval process for a procedure has to do with clinical trials, studies, large studies that are done on human beings to evaluate comparative benefits versus the risks and then the outcomes of that procedure. And if they are clearly favorable to patients, then they are recommended as part of medical guidelines. If they are clearly detrimental, then the recommendation is, it used to be labeled as should not be done or as inappropriate. Now it's felt to be rarely appropriate, that there could be a situation that would be helpful, but generally speaking not. And then there's situations in which they're in that gray zone. So people in whom it would definitely be beneficial, people in whom it would be rarely but could be beneficial, and then people in whom most of the time there will clearly be some benefit. Generally speaking, cardiac ablation has been very well studied and is approved by most insurances. Cardiac ablation is performed in a hospital setting, and that's largely because the tools and the technologies that we need often will be housed in an operating room or an electrophysiology procedure lab. Most electrophysiology procedures today are done on an ambulatory basis, so people can come in and go home the same day. There are some situations in which the procedure may be higher risk or the person may be at higher risk, where we observe them overnight or for a longer period of time, or the duration or the severity of the procedure was quite extensive, and so they need to stay in the hospital longer. But in general, these are outpatient or ambulatory procedures that are done in a hospital setting. During a cardiac ablation procedure, patients are brought to the electrophysiology lab after an extensive discussion of the risks, the benefits, and the alternative treatments. And through a shared decision-making process, the patient and the doctor, and often their family, will arrive at a decision to proceed with cardiac ablation. At that point, the procedure is scheduled, and the procedure is performed in the electrophysiology lab. Generally, those patients are fasting. They are brought to the lab, and then usually they will receive some level of sedation. Could be light conscious sedation to general anesthesia. Almost invariably, electrophysiology procedures require putting catheters into the heart via the blood vessels, typically the top of the leg, sometimes the bottom of the neck, top of the chest, and the arms. All of the veins that are used and sometimes the arteries all allow the catheters to travel to the heart to then record electrical impulses from the areas that are relevant to map out where the arrhythmia is coming from. In conjunction with that, we use three-dimensional mapping systems to create a 3D virtual reality model of the heart that can show us the structure of the chamber that we're mapping, that can show the electrical activation pattern of the arrhythmia that we're mapping, can show us areas of scar and recommend potential areas of relevance to the arrhythmia. All of this is done either under image guidance or under X-ray. And then one of those catheters that are delivered up to the heart will have an electrode at the end of it that you can deliver energy, whether it's cryo, whether it's radiofrequency, whether it's laser or pulse field. And the catheter itself has a deflectable shaft and a tip that allows you to direct through rotation and deflection the catheter tip to the point of to the area of interest, and then we can deliver energy through the catheter. The energy that arises is created in the generator, and we can deliver energy through the catheter to result in a controlled destruction of tissue, often during the arrhythmia itself. So we get the opportunity to see the patient convert when we ablate from the arrhythmia back to normal rhythm, which is one of the strongest indicators of success during the ablation procedure. The procedures can take 90 minutes, sometimes even as short as an hour, or they can go for several hours, depending on the arrhythmia that's being mapped, the anatomy that's involved, the variety of tools that are being used, and often even the number of doctors that are involved. Sometimes it's multiple physicians are collaborating together to achieve a success for the patient. Cardiac ablationists have undergone extensive training in cardiology and then cardiac electrophysiology after they've finished their medical residency and certainly after, which is preceded by medical school. So it often is a 10 to 12, even 14-year training period that will include not only medical training and specialty training in this, but also research. Because all physicians are also scientists. We are taking care of patients, and at the same time we are identifying problems and coming up with solutions. And so the field itself is still evolving. And so the training that I did to get to where I am today is going to be different than what the training of the electrophysiologists of the future will do. It may be truncated, or it may be different areas. We may not see maybe cryoablation or radiofrequency ablation or laser ablation. Maybe it'll be pulse field and the next levels of treatment. Maybe we'll learn how to ablate with sound only. We'll learn how to ablate with non-invasively using radiation. Maybe we won't be using catheters anymore. And so training will be dramatically different. But understanding the physiology, gaining an understanding of that through medical school and residency in cardiology and electrophysiology is still paramount to being able to be successful as a cardiac electrophysiologist on behalf of your patients. Cardiac ablation is, generally speaking, very safe. However, there are some attendant risks. The most important risks related to cardiac ablation are the potential for having a stroke, the potential for a perforation of the heart, which leads to fluid accumulation or blood accumulating outside the heart, compressing the heart, preventing it from beating and causing cardiac standstill and death. And in order to treat that, people need to have open heart cardiac surgery to alleviate that problem quickly. There can also be complications related to the specific location of ablation that could render somebody needing a pacemaker because their own electrical system was damaged through the process, through the ablation. And then there are some more minor complications such as bleeding at the access site or allergies to a particular medication like a sedative or an anesthetic that was used. But the major life-threatening complications, having a stroke, having a heart attack, needing open heart surgery to fix a problem that happened in the lab, the likelihood of that is, in total, somewhere in the range of 5 to 10 in 1,000. So about 1% or less. In some instances, the arrhythmia that's being ablated cannot be cured, and so many people may need repeated ablations periodically when the arrhythmia recurs. In some instances, the chance of cure is very high, and yet it's not 100%. So even if there's a 2% chance of having a recurrence of an arrhythmia that would require a subsequent ablation, it's not necessarily the same arrhythmia that was ablated the first time. It could be a different arrhythmia that arises. But yes, people can have multiple ablations. There is no statute of limitations on the number of ablations that somebody can have. And it's always a risk-benefit analysis of the likelihood of success versus the damage that's going to be created versus the goals and what we're trying to achieve. Yeah, depending on the arrhythmia, the outcomes after an ablation do vary, but almost overwhelmingly, the likelihood of cure from an arrhythmia is very high. In a couple of conditions, there is no cure, such as ventricular tachycardia in the setting of ischemic heart disease, which means a prior heart attack, or in atrial fibrillation. In that case, we don't talk about cure, but we talk about how long we can keep that arrhythmia suppressed, not occurring, or so-called under control. Analogous to the way that people refer to cancer not being necessarily curable, but in remission. And so we like to, in AFib and in ventricular tachycardia, generally speaking, we like to get those arrhythmias into remission or suppressed for at least a year. And that's the time window that we use when we're talking about the likelihood of success. Is it 100% or 80% or 90% or 40% chance of staying in normal rhythm through the course of that next year after the ablation? That's the statistic that typically is used to gauge the success rate. So for people with early, newly diagnosed paroxysmal atrial fibrillation who are undergoing ablation, the likelihood of success, meaning staying in sinus rhythm for a year after the ablation, is about 80-85%. In some studies, even as high as 90%. For people who have persistent atrial fibrillation, that statistic drops to about 60%. And for people with long-standing persistent, it's 50% or less. Catheter ablation today is very minimally invasive. So we do ask them to restrict bending at the access sites, typically the groin, to allow the puncture sites to heal. That's typically for, in most physicians or in most organizations, 2 to 5 days of so-called laying low, and then starting to gradually increase the weight bearing and the bending and the activity. Typically by 5 days, if somebody has had catheter ablation only done through veins, or maybe 10 days if the arteries were used, can people very reasonably expect to be able to get back to full activity without restrictions.